Next up is Dr. Barbara Kowalcyk. And Barbara, you can present from there, or if you want to go to the podium over there, wherever you're most comfortable presenting.
Maybe up there we have it set up for her.
Okay, you're set up over there. Dr. Kowalcyk, as she introduced herself earlier, is an assistant professor in food science and technology at The Ohio State University. And as with all of the other speakers, her bio sketch is included in the package of information. So, Dr. Kowalcyk.
Okay, great. Thank you, and good morning. Thank you for the invitation to come speak. So what I'm going to be talking about today is developing risk-based frameworks for food safety in low and middle income countries. So as most of you probably already know, food safety is an important global public good. It's critical to food security and nutrition, and it causes a significant, foodborne disease causes a significant amount of illness globally. The World Health Organization estimates that there's 600 million illnesses per year, and children bear most of this burden. And one of the areas that I research that is not well recognized is that there are many long-term health outcomes associated with foodborne disease, ranging from things like irritable bowel syndrome and reactive arthritis to kidney failure and some different psychological and cognitive developments. Not surprisingly, these illnesses and failures in the system have significant economic impact, ranging from medical costs, lost productivity, loss of consumer confidence, and particularly for developing countries, reduced market access. And of course, when we have failures in our food safety systems, we end up with increased food loss and waste, as that food is not eligible to be consumed by the public. So I'm sure that you have maybe seen this graphic before. I almost always include it in my talks because I think it really demonstrates the complexity of our food supply and how it really is global, and we need to be treating food safety as a global issue. Of course, this graphic comes from the National Academy of Sciences. And it's not surprising, given the complexity of the food supply, that we have failures in the food safety system all the time, make headlines, and these are just a few of them. Some of them are kind of old, but we have them almost on a daily basis. Now, recently, and maybe you've already heard about this, but the World Health Organization developed the first ever global burden of disease estimates for foodborne illness. And this has really driven a lot of interest in foodborne disease. So they estimated that globally, 1 in 10 people fall ill per year, and there are 420,000 deaths. About a third of those happen in children, resulting in 33 million healthy life years lost. This puts foodborne illness on the same magnitude as HIV and tuberculosis, yet foodborne disease has not gotten nearly the amount of attention that those other illnesses have had. So FERG also looked at the global burden of disease by region, and you can see here on this graphic, I didn't include all of the breakouts, but Africa has the largest amount of burden. Here's the United States, Canada, and Mexico are right here, so very small burden. But the one thing that also strikes me when looking at this graphic is the pathogens of concern vary from region to region. And I'm going to be talking about some work that I'm doing in Africa, and specifically in Ethiopia, which is within this Africa region E, so right here. So you can see diarrheal disease is still a significant part of their burden, but you also have chemicals and drugs and helminths and some other agents that are of concern. Okay, so food safety really matters for development, but unfortunately food safety has been largely neglected. When I first started working in food safety 18 years ago, most of the response I got was, well, food safety is important, but first we have to get food into people. And so food security and nutrition are more important. And I would often argue that if it's not safe, then it's not nutritious and it's not secure. And I'm happy to say that conversation seems to be changing. And people are starting to understand that you cannot have food security and good nutrition without food safety. So Even so, it's still, there's a lot parts of the world where food safety is not necessarily seen yet as a priority. So that's a problem for development. And of course, developing countries bear most of the burden, as you saw in that graphic. Yet it's not well quantified. I will say that those estimates that FER came up with have a lot of uncertainty around them. So those estimates are probably on the lower end. They didn't include most of the chronic sequelae associated with a foodborne disease. So there's a real need to get better estimates of the burden. Food safety is being driven by intensification of agriculture, increased consumption of high-risk foods, and lack of effective food safety systems, which we need to address. And of course, the lack of strong food safety systems leads to barriers to export markets and even barriers for domestic markets, particularly for your smallholder farms and women, and informal markets tend to dominate in low and middle income countries. There is increasing concern among consumers in those countries about food safety. It still needs a lot of work. And one of the challenges is there's limited evidence on effective, sustainable, scalable interventions. And one of the things that a lot of low and middle income countries do is they turn to Europe and the US and look at our systems. And yet our systems are very different from their own. And what may be effective here or may be a high risk here is not necessarily representative of what would be best in their country. So I'm going to talk about Bill and Melinda Gates and United Kingdom Department for International Development grant that I just recently got to look at food safety in Ethiopia. The title is shown here, but we call it TARTARE. And one of the reasons we call it TARTARE is raw beef and raw milk are consumed in Ethiopia. Culturally, they eat a lot of raw beef and raw milk. And those are the two supply chains that we're looking at. And of course, TARTARE means raw in French. So we thought that would be an appropriate acronym for our study. So this is a 4-year project for $3.4 million. And we were just awarded in late November, so we're still in the initiation phase. But the goal of this project is, the overall goal and long-term goal is to increase equitable consumption of a safe, affordable, and nutritious diet by specifically reducing morbidity and mortality due to foodborne disease. And we are going to, as I said, focus on 2 value chains, raw beef and raw dairy. And we're looking at 3 major foodborne pathogens: salmonella, non-typhoidal salmonella, campylobacter, and we broadly said diarrhegenic E. coli, but probably S-tech within that. And we're going to be using this, Ethiopia, as a model for other low and middle income countries. So our main goal and outcome will be to develop a risk-based framework in Ethiopia that will address important data and knowledge gaps in understanding the burden of foodborne disease. Then we're going to, so I have these 3 pillars. One is burden of foodborne disease, and then the second one is going to focus on risk mitigation. And specifically, we're going to develop and evaluate cost-effective, gender-sensitive, and socio-culturally appropriate approaches for mitigating impact of foodborne disease in the 2 supply chains that we've identified, raw beef and raw dairy. And then we are going to, the third pillar of the project is to engage stakeholders and the government in a risk ranking and prioritization exercise that will help them develop a model for improving food safety governance in their country, and specifically allocating their limited resources in a way that it will most effectively impact public health. So the key outcomes is this risk-based framework, and the second key outcome is increased in-country resources. And while this is a research study, ultimately my team, we look at this as a capacity building study. Our goal is to help them start to develop a risk-based framework that will be sustainable into the future, and that they will have the human capacity in country to be able to move this forward after the project is over. So I like to show this graphic because really what we're trying to do here in Ethiopia is build an integrated food safety system. They don't have a very formal food safety system in Ethiopia, and that does give us the opportunity to build one from the beginning. But the reason I like this, besides the fact that I work in risk assessment and epidemiology, I'm also a big proponent of One Health. So you can see here, animal contact, food, pathways, environment, all lead to exposure and disease. And then epidemiology and risk assessment working in conjunction with each other to generate data and improve the process. And of course, no system actually, as much as scientists we would like system to be fully informed by science, it's not. There are values, change, costs, and choices that are operating around the system that the system actually has to take into account. This is the definition of a risk-based approach based on a National Academies of Science committee that I and Julie Caswell served on. So Julie this should look similar to her. So this was part of the committee looking at enhancing food safety and the role of the Food and Drug Administration that came out a while ago. And one of the things that the committee sat down and talked about first was what is a risk-based food safety system? Everybody talks about it, but there were no good definitions of it. So we set about defining it, and these are the key criteria that we felt that a risk-based food safety system should have. It should be proactive and data-driven, grounded in risk analysis. And for those that you don't know about risk analysis, that's really looking at risk assessment, risk management, and risk communication. A system that is systematic and transparent, ranks risks based on public health impact, prioritizes the allocation of resources so that it can most effectively mitigate risk, and considers other factors in the decision-making process in a transparent way, and then involves all stakeholders in the process. And so this is what we define to be a risk-based system, and this is the definition that I am using in this project. So if you really want to boil it down, the burden of disease is really critical to a risk-based system. It's one of the foundations. So in a risk-based system, what we want to do is we want to take these risks and we want to rank them in some way to figure out where they're going to have an impact. Now, a lot of people think about risk. Risk has two components: the likelihood that it will occur and the severity. How bad is it when it does occur? And so a lot of people like to use DALYs and number of illnesses and all of that, but I actually like presenting it this way because it captures both aspects of risk. So for example, if you look in the US, STEC does not happen a lot, but when it does happen, it's really, really bad. And that's why it gets prioritized over other pathogens like norovirus. So you can see here, highest likelihood of risk, highest severity. And here is a graphic that I like to show from the Netherlands, where they've done this. And the little triangles are the point estimates. These circles, dots around it represents the uncertainty around that estimate. And for me, this is a much more meaningful graphic than any number of tables could possibly be. But this is the point of a risk-based system. We rank out the risks, and then as a group, as a society, we have to make decisions on where we're going to allocate these risks. Does severity of illness drive our decision-making more than the number of illnesses? So if we were looking at number of illnesses one of the things I will say most is happening is toxoplasma is popping to the top. But, if you were going to look at number of illnesses, you might be looking at norovirus and Campylobacter to focus your efforts. So here's a very complicated graphic. I'm not going to spend much time on it, just that this is the results framework for our project. There's a lot of moving parts in it, but I'm going to go through our methods for the three main areas and then the capacity building. So the first pillar, as I said, was we want to understand what is the burden of disease in Ethiopia. Now, if you go back to those WHO burden of disease estimates, Africa has over 91 million illnesses per year from foodborne disease, and about 70% of that is from diarrheal disease. And they account for a significant proportion of the overall deaths in the global burden of disease estimates. Okay, but in Ethiopia, they do not have any surveillance around foodborne disease. They have surveillance around 21 pathogens, but none of them are foodborne pathogens. And so how do we get an estimate of foodborne disease without a surveillance system? And so that's what we're going to be doing. We're going to conduct 4 epidemiologic studies to estimate the incidence of illness caused by these 3 pathogens, and then we're going to develop burden of disease and cost of illness estimates. Now, the challenge in estimating burden of disease is always, here's what we see, even in best case scenario through surveillance system, and here's the total burden, what we really want to know. And even in the United States, we have a small fraction of illnesses reported, and how do we deal with this in Ethiopia where they have no surveillance system? We also have the issue that foods are contaminated by many agents, that you can have exposures through many pathways. We have a large number of unknown agents, and burden includes acute and chronic illness, but primarily people have focused on this acute piece. So what we're going to do is our first study is going to be to look at hospitalized cases of diarrheal disease. And we're going to do a descriptive epidemiologic study in that population in 3 areas of Ethiopia. We're going to look at this is going to be a prospective cohort study. We're going to look at the incidence of lab-confirmed cases. We're going to extrapolate to the number of lab-confirmed cases in the country. We're going to adjust for the number of stool samples properly tested, so we're going to be doing some laboratory surveys to be able to understand current practices, and then we're going to adjust for the proportion of stool samples collected. Our second study is going to be a healthcare worker study, and this we will randomly select healthcare workers around the hospitals involved in the descriptive epi study, and we will be asking them a range of questions around their treatment practices and referral practices. So this will allow us to adjust for the proportion of patients who are hospitalized and who seek healthcare. And then we're going to conduct a population survey or community survey, and we're going to select people in Ethiopia are assigned to a healthcare clinic. So we will, from the healthcare workers selected, we will select members of the general population out of those clinics and do community surveys so that we can come up with an estimate of illness in the country. There will be a lot of uncertainty in these estimates, but it's better than what they have currently. And knowing that we have a lot of different exposures and certain pathogens are endemic in the population and they may not actually cause illness, we're going to conduct a case control study in children under the age of 15 with and without diarrheal disease. And our hope is to use, if we can arrange to get the equipment and supplies in country, is to use a culture-independent diagnostic test that has, for a GI panel of about 22 pathogens, so we can get a good sense of how many pathogens are people exposed to and which ones may actually be causing illness. So the second pillar of the study is mitigating risk. And here, as I said before, we're going to be looking at cost-effective and developing cost-effective and culturally acceptable approaches. So there's 2 things that we're going to do. We're going to actually evaluate the effectiveness of these 4 mitigation strategies, 2 in the beef value chain and 2 in the dairy value chain. And then we're going to use risk assessment to estimate the public health impact. And then we're going to do cost-benefit analysis to estimate the feasibility of implementing these strategies wide scale. These are very small studies, and the goal here mainly is to help build capacity in country to do these types of studies and having the recognition that we need to have, you need to evaluate these intervention strategies before you put a lot of resources into them so that they can, because that can be very costly. So here are the intervention studies we're looking at. We're going to do 2 training intervention studies. These training studies training materials and curriculum were already developed by other projects but have never been evaluated. So we're going to look at these 2 training programs. We're going to do CAP surveys, knowledge, attitudes, and practice surveys, pre and post training, and we're also going to be collecting some microbiological samples pre and post training to look at the effectiveness effectiveness. Then we are going to do 2 processing interventions. One, in Ethiopia, they have a product called Quanta, which is a type of jerky that's homemade. It's very high risk. So we're going to see if we can validate a jerky processing procedure, and we'll test it for consumer acceptance. And then the other thing that they do is they eat a lot of yogurt and soft cheese. And most of the time this is made with unpasteurized milk. They let the milk sit out at room temperature for a period of time. They might use a backslot method, and it's a high-risk product. And they don't like to use starter cultures as a way that you can use starter cultures to outcompete some of the other bacteria, but most of the commercially available starter cultures make the products taste European or American, and they don't like the taste of that. So one of the things that we're going to do is we're looking at developing starter cultures that are specific to Ethiopia, and will produce products that taste Ethiopian but are a bit safer. So here's just a risk assessment diagram, and I'm not going to go into depth because I think I'm running out of time, but this is the framework that we're using. So once we conduct those evaluation studies, we will conduct a risk assessment to look at the overall impact of implementing them broad scale, and then we will come over here and look at the cost-benefit analysis of implementing them. So the third pillar is ranking and prioritizing risks. So the real question is, Ethiopia has limited resources. Where should they be allocating their risks to effectively reduce foodborne disease? And there's lots of different things that you have to take into consideration. So the first thing we're going to do is map current governance systems for food safety in Ethiopia. And then we're going to engage stakeholders in a risk ranking exercise. And this is the framework that we're going to be using. A few years ago, I was on a team. We worked with FAO to develop a risk ranking guidance, which FAO promises me is going to be published soon. But one of the challenges is that lots of times low and middle income countries will look again to the US and Europe and say, well, these are your high risk foods, these are your high risk pathogens, that's what we're going to do. Or they'll say, we're going to undertake a risk ranking process exercise, and we want to do a fully quantitative approach, including all foods, all hazards. Well, the United States doesn't do that quite yet, so that would take years. So there are lots of other approaches, and the biggest part of this, we developed this guidance in conjunction with a lot of experts, is focusing on the scoping exercise and screening down what's relevant for this context. And then you pick your method and you do your analysis. And the method could be driven by the data that's available. It could be driven by the method that you want to use. It could be driven by the metrics. So we drew this as a circle because any one of these 3 components could drive your risk ranking activities. Now, when we did this with FAO, we did not have the resources to pilot test it, so that's what we're going to be doing here in this project. And so we'll engage stakeholders in a risk ranking exercise to take them through this, and then after that, we will engage stakeholders in a prioritization process, and the idea is to develop a roadmap for them to go forward after this project is over. So here's basically the way it works. In theory, you identify risk, estimate risk, either using a bottom-up approach across the supply chain or a top-down approach from disease. That's what we're doing both. We're doing mainly top-down, but we're going to use a risk assessment to do the bottom-up. You take the risk assessment, stakeholder opinions and values, and the cost-to-benefit analysis. You use some sort of decision-making process to come up with a map forward. And this is the process we're going to walk them through. Now, as I said, this is really a capacity-building project in my mind. So we're going to be increasing food microbiology capacity building. This is a picture, just to give you an idea. One of our biggest challenges is lab capacity and food micro lab capacity. This is the food micro lab at EPHI, which is the Ethiopian Public Health Institute, which is basically the equivalent of our CDC. What you notice right away, there is no roof. And you can't see it over here in the corner. There is a dirt floor, and there were birds flying around in the lab. And so one of our challenges is how do we bring this lab up to capacity to analyze the samples that we're hoping that they'll analyze. Now, one of the things, so we're going to be providing some equipment, just a little bit. We're going to be working with them on facility improvements and training and mentoring. And one of the things, that the feedback that we got, is they have the money to renovate this lab. They just don't know how to do it. And so one of the things we're working on right now is coming up with a list of recommendations of how do they bring this lab up to real capacity. The other piece that we're finding out is that human capacity is their biggest need. So we have 5 pre-doctoral fellows, one for each area, that will be engaged in this study. These are people in Ethiopia who are working on their doctorates, and we're currently recruiting for those positions. Ohio State also runs a One Health Summer Institute. It's been going on for the past 7 years. We go in country and teach. So we're going to be doing some specific courses through this that will address this capacity. And we're also engaging with CDC Ethiopia Field Epidemiology Training Program. They have several residents that they will be engaged in the process. And ultimately, our goal is to improve risk-based decision-making in the country. So with that, I just want to, this is the team from Ohio State. OSU has a Global One Health office in Ethiopia, University of Florida, ILRI, and then several universities in Ethiopia. We are funded by the Bill and Melinda Gates Foundation and the United Kingdom Department for International Development. I would like to mention that under this Gates and DFID call, six projects were funded globally. 4 of them are being conducted in Ethiopia. And these are the 4 projects. We've been asked to collaborate with all of these projects, and we had a joint inception meeting in February to kick it off, and we regularly communicate. Just to give you an idea of where the orange is TARTARE, but this gives you an idea of where all 4 projects are working within Ethiopia, and you can see there's quite a bit of overlap. Ensure, which is from Addis Ababa University, and they're looking solely at dairy, and TARTARE are the only 2 that are working only in Ethiopia. And so I'd like to end with, this is our goal, is to have an integrated, holistic, systems-based approach to food that's proactive, preventive, and anticipatory, addresses One Health, and delivers safe, sufficient, and nutritious food for all. And those are my references, and thank you. I'd be happy to take questions.
Great. So members of the committee, questions? Veronica, why don't you lead off?
Thank you very much for a very interesting presentation, particularly the research that you are now embarking on and giving us a big overview of the project that you're embarking on. I have 2 questions. One is related to what you said about data on foodborne diseases, and you were addressing this kind of lack of data or gap by doing a specific study in a hospital and saying how many patients are admitted for the X disease, etc. What would you say if the committee thinks about making recommendations in the line of how could we fill that gap, and for instance, proposing to include in household surveys routinely the question on foodborne diseases? So we know that USAID supports many countries, including Ethiopia, to do household surveys. They include questions on TB, they include questions on HIV, and you alluded to the fact that actually foodborne diseases have a higher burden, so why not including? So that's my question number 1. Would you suggest that's a meaningful way to address the gap on data? And my second question is a little bit on the balance or the inherent tension that we see on stronger regulation / investment or cost incurred versus profit making. So when you talk about farmers, you talk about farmers having these products and producing them and selling them. if we suggest there should be higher standards, including, for instance, pasteurization, this will come at a cost. And usually we see the inherent tension of more regulation, more costly, and then how do farmers react to that? Is that actually a proposition that we can make? If you can comment on this inherent tension. Thank you.
So first, I think it would be an excellent idea to include questions on diarrheal disease and foodborne illness on surveys that are being conducted already. I think Ethiopia is one of the GEM sites, so we're going to be looking at those surveys. And even when we do our CAP studies, surveys, we're going to be asking about diarrheal disease among the food workers. So I think the more information we could get and making that a standard question would be a good idea. On the tension between cost and regulation, that's a very good question. I think that that's part of the prioritization process. Is they have to make those societal decisions. Those aren't necessarily scientific ones, but that's part of what society needs to consider. Now, for example, the obvious answer to raw beef is don't eat it. Just cook it first, and for raw dairy, it's to pasteurize it. But it's not culturally acceptable to say that right now. So one of the projects, Pull Push, that's also being conducted in Ethiopia is similar to the type of project that we heard about from India. They're actually looking at doing outreach with consumers to create a demand for safer food. And I think that that's probably, at this point, the better way to go than regulation in Ethiopia, because they don't have the framework or infrastructure there to effectively regulate at this point. So what we're trying to do is help them start to build that, and recognizing that in their risk-based system, initially, risk-based systems are not one and done. It's a continuous improvement cycle. And so as you continue, you're going to get limited data in the beginning. You're not going to be able to do everything you want to do. But as you collect more data and as you keep reevaluating, you might eventually get to the point where you can look at the cost of regulation versus profits. But most of the producers we're looking at are not the large commercial producers in Ethiopia. We're looking at we call them the semi-commercial. So these are very small producers.
Thank
you, Chair, for giving me this opportunity. And I appreciate for your excellent presentation. I have one question. Of course, I agree with you that the burden of foodborne diseases is not known in developing nations. It's not only because there is no system for investigation and surveillance of foodborne diseases, and therefore it's not possible. They don't also do mapping of food safety hazards, and therefore they cannot make risk profiling and rank areas which are of high significance to the food consumers. But there is one area which we normally don't consider in most low-income countries. And majority of the people live in rural areas. They produce and eat. And therefore, there is no system of monitoring level of contaminants in those foods which they eat. And therefore, you cannot really say the type of health problems they are experiencing is a foodborne. And I think this is one of the areas. Also, when we are doing in Ethiopia, we should take into consideration that majority of the people, they produce and eat, and there is no mapping. My experience in Tanzania is that initially we are not doing research on the level of mycotoxin contamination in food. When we started conducting research on levels of foods which are susceptible for mycotoxin contamination, we discovered that there are some of the foods which had high levels, and there are incidences where there was acute aflatoxinosis. Thank you.
Thank you. Did you have a question, or did you just want me to comment?
It was a comment.
Okay.
I wanted you also to see if you can take into consideration when you are conducting research.
Yes, we will. And of course, just going back, this $3.4 million in 4 years sounds like a lot of money. and a lot of time, but it's not. It goes by really quickly. So one of the things we tried to do was pick something that's manageable. And we also, early on, we were asked to collaborate with the other 3 studies. So we took what they're doing into consideration when we were developing, when we were finalizing our work scope. But I agree with you that one of the things that we do need is surveillance, not just human surveillance, but food and environmental surveillance. One of the Addis Ababa University project called Ensure, they're doing a prevalence study in dairy across the dairy supply chain. So we'll actually be using their data in our risk assessments. So rather than focusing on doing surveillance of a supply chain, we're focusing more on the risk-based system. But I think you're correct. There needs to be an understanding of what are the risks out there. But the approach we took was we have to start somewhere. Right? And what we have to do right now needs to be manageable within the time and resources that we had.
Great. Thank you very much. We're running a little bit over time. We've had 2 terrific talks to start things off. Dr. Kowalcyk is going to be participating in the panel discussion, so if we could hold questions for her, and we'll take them up again after lunch. But thank you so much. And at this point, let's take a 7-minute break. You want to tell people where the facilities are?
If you just go out here. 5 to 7.
10:37.
Yes.
Thanks.